So hyperkalemia and acidosis. So what happens in these guys? So remember, a big detective here, we can be giving a cocktail, right? So A for albuterol is going to help lower our potassium, because when you attach to a beta receptor, whether it be beta 1 or beta 2, especially beta 2 on our cells, that's going to cause our cells to activate some channels and open up little K channels and allow K to come in and exchange for sodium, right? So that's the idea with our with albuterol. It's going to push it into cells. So we got albuterol there. It just pushes it into the cell. The cell can be full of potassium, but you're going to give these medications as a temporizing measure, right? And albuterol is usually like a hefty dose. It's not like the dose you get every 4 to 6 hours. It's like a huge dose, like I think it's like 5 milligrams or 5, not grams, it's like 5 milligrams. And it's like over like an hour, or even over like continuous over 4 hours that you're giving this dose of albuterol. And that's going to push it into the cells, right? And then some other things could push it into the cells. We could push it in with insulin and dextrose, and those are actually the ones that are the most effective, right? So we got insulin and glucose are other things we can do to push the potassium into the cells so that it stays there, okay? And sodium bicarb is going to be is make you alkalotic. As we know, K and hydrogen like to switch places, right? If you make someone give someone bicarb, the K is going to go down. It's going to neutralize the hydrogen ions, and therefore we're going to have a drop in the K. And we'll point this out more when we talk about hyperkalemia next time. With hyperkalemia, in the cell membrane, everything's going to start moving across based on changes in electrolyte levels. Okay, so that's how we're going to be pushing things into cells to help it get out of the serum, because if it's in the serum, what's going to happen? The K is going to go up and up and up, and what's going to happen? We're going to start getting peaked T waves. We're going to start getting everything going to start getting prolonged. Everything gets prolonged. Nothing gets short. So you get peak T waves. If you imagine if you just grab it right here, the tip, and you pull it to the right, everything gets prolonged. So prolonged PR, prolonged QRS, prolonged QT, prolonged QTC. Everything is prolonged until it is what? Sine wave or asystolic, right? So that's, you can see here you got peak T waves, and it just goes to a sine wave to where it then becomes asystolic, right? And why are we at risk for hyperkalemia? Because we're not getting rid of it. And if we're also not getting rid of it, we're also not getting rid of hydrogen ions. And hydrogen ions and potassium, your body's like, well, what's the worst of the two? What's the worst of the two evils, right? So it thinks, so potassium, right? Because I need a heart to be able to beat. So it puts the potassium into the cells in exchange for hydrogen ions. And vice versa, the hydrogen starts getting higher, and then it's like, well, shoot, my hydrogen ions are high, then my heart can't beat. So let's put the hydrogen ions back in the cells in exchange for potassium. Oh, well, shoot, now I'm hyperkalemic. So I'm just gonna hopefully just do this until the kidneys kick back in. Well, hopefully the kidneys kick back in, right? So that's why we're giving these agents to push things around for the patient, right? So definitive ways to get rid of the potassium is we can pee it out. We can do what's called kaliuresis, right? You are diuresing with K-wasting diuretics, right? So we are going to waste the potassium with furosemide. That's usually our go-to agent, right? So furosemide or bumetanide, Bumex, these guys are going to help you pee it out. That's if you have functioning kidneys. If your kidneys are not putting any urine out, that's not going to help very much, right? Another definitive way is if they are pooping, poop it out, right? So we have sodium zirconium, which is our new agent, Lokelma. That's usually our go-to guy that's going to help poop out the potassium. It's going to bind it in the gut, and it's going to be pooped out, right? And patiramir is another agent, and then Kexlate. Kexlate was retired in 2014. We don't do Kexlate anymore, right? So that's an agent that's going to actually cause bowel obstruction and be very, very bad for a patient that needs to poop out the potassium. Potassium is going to cause a bowel obstruction, cause an ileus, cause acidosis or ischemic colitis, and that's going to cause even worse outcomes. Okay.
Do you find people still prescribing KX?
Kicks it all the time. Yeah. So you just gotta say, can we try, sodium zirconium, right? I bought some sodium zirconium rings for my girlfriend, so I think maybe that'll work, right? Potassium is great, right? So that's another agent. That's someone who went in the wrong part of eBay. So yeah, so you want to make sure that we are getting a potassium level under control. So checking the potassium levels is important, and also checking ABGs, yes, but also the CO2 and our chemistry, right? To fix the metabolic acidosis, we can do a bicarb drip. So bicarb drip is preferred in infusion, or you can do bicarb tabs if they're really at risk for fluid overload. Little bicarb tabs 3 times a day can help neutralize acids that are building up. And then of course we give them the routine around the clock agents that they're going to poop out, right? We can't give them like Lasix around the clock, like to send them home with it. Usually these are the agents that we poop out are the ones we give them to send them home with. Okay, and just going back to the cocktail here for C down here, calcium. That's given when you have EKG changes, right? Anytime there's an EKG change or an inkling EKG change, someone says my patients have EKG changes and they're hyperkalemic, automatically calcium, right? That's going to stabilize the cardiac membrane and allow it to depolarize, repolarize normally. Okay, so that's the idea with giving this potassium cocktail. The other definitive way to take out someone's potassium, because they're not peeing, they're not pooping, and you tried all the therapies here to try to push it into the cells, and then it's just going to make its way back out into the bloodstream, is to do dialysis, right? So we do renal replacement therapy or dialysis. That's going to be a permanent way to take out someone's potassium. You take the blood out of their body, you manipulate it, and you take out the K, right? So just like the rapture over here, right? So you're going to take all these potassium being taken out, and in Vegas, just one, right? So that's the idea with a potassium management, right? So acidosis and potassium can both be high, and we have to fix the potassium, but also you have to fix the hyperkalemia. So, or sorry, the acidosis, which causes hyperkalemia. And some things to fix with acidosis is not allow other acids to develop, to build up. And again, those are acids such as K for ketones, or these acids will kill you also. I for ingestions, you want to make sure they're not ingesting other things that might be acidotic. And L for lactate. Why does your lactate go up? It'd be a lactic acidosis from like an infection, for instance. So treating the underlying infection would be a key measure to help these guys out. Okay, so chronic anemia. So anemia happens because our kidneys are not producing what? Erythropoietin, right? So EPO is one of our important functions of our kidneys to produce. It produces it when oxygen levels are low, and obviously oxygen levels will be low when our RBCs are low. So that's what it does normally. It's normally producing EPO, and it'll produce more EPO when oxygen is low, right? Oxygen is low, we produce EPO. But what if the kidneys are broken? Then you're not producing EPO anymore, right? So we need to make more. So that's why we get our anemia. We get our symptoms: chest pain, shortness of breath with clear lungs. But again, if they have kidney disease, they might have some fluid overload, because that's that's one of the other complications of CKD. They have the SNS firing off. They get pre-syncopal. No one dies from anemia, like from the anemia itself. They die from the complications of anemia, and the complications are syncope and a fall. So now you have a head injury, and now that's going to be the problem, right? The other problem is when your hemoglobin gets less than 5, what happens? That's an MI. So you get it from a complication of the anemia, not from like the anemia itself, right? People can tolerate hemoglobins of 4, 3, even 2 even. We've seen like crazy hemoglobins, all right? And with less than 5, that's where you're going to start getting the MI. They're high risk for that, so they need to get transfused, okay? So then there's another hormone involved here called hepcidin, and it rears an ugly head inside of chronic kidney disease, because when your EPO is not being produced, you should be, what's going to happen is you're going to be, one of the consequences, you get inflamed, right? You have all the inflammatory markers you can't get rid of in kidney disease, and inflammation itself is going to trigger is going to stimulate hepcidin, right? And hepcidin is what you need to absorb iron from your gut. So if you absorb iron, you can't absorb iron from your gut if hepcidin is around. And hepcidin is around when you are inflamed. And you're inflamed when you have chronic kidney disease and have low EPO. So it's like how are we going to fix this problem, right? So you have decreased erythropoiesis when you have a inflammatory process, right? And what else can happen is you try to fix the anemia. You fix it with PRBC transfusions, right? When the PRBCs are less than 7, or hemoglobin is less than 7, we give packed RBCs, and that should fix their anemia. But what do PRBCs have in it? They have hemoglobin, and heme is made of iron, and the iron actually stimulates it tells your body, oh, I got plenty of iron. And when you have plenty of iron, your hepcidin is like, hey, we don't want you to have hemochromatosis. What's hemochromatosis? That caused liver failure, right? That was one of our causes of liver cirrhosis was hemochromatosis. And your liver's like, we're not having that. I don't want you to get any high iron. So we're going to stop the GI absorption of iron. but I need the iron for the EPO, for my kid to make RBCs, don't I? But your hep C is like, nope, we can't have too much iron. It's going to damage your liver. So ironically, the treatment for what makes the EPO even lower and what makes us difficult to absorb iron in the first place is the hepcidin, and hepcidin goes up when we need the iron in the first place. And the treatment for it is to give, we got to work around it somehow, because giving PO iron is not going to work because they have this chronic inflammation, this chronic high iron in the bloodstream, and this nasty hormone gets around that's going to inhibit this whole process. It's stopping everything. Right? There's some like newer agents that are actually stopping the hepcidin itself, but what we're going to do now is just give PRBCs or give IV iron that can help someone's anemia. Right? So if we can, we'll give iron and folate and B12, all the fun stuff to help stimulate blood production normally, so they have the tools necessary. But really, it's hepcidin that's going to start throwing a wrench in that plan. Right? And iron itself is constipating, so it can be, and it's better absorbed when you have vitamin C. That's usually why vitamin C is also in what are called nephrocaps, right? The nephrocaps are the multivitamins for renal patients. And renal patients in their nephrocaps, they should have B12, they should have vitamin D. And what should they not have in those nephrocaps? Potassium should not be too high. They should definitely not have what? Should not have phosphate, right? Because the phosphate is going to be high. So going back to BUN being elevated, right? So BUN normal about 12 to 20, right? And if we can't get rid of BUN, it's going to start building up, and BUN crosses membranes you don't need a BUN channel. A BUN just goes anywhere at once, right? So it can cause uremic pericarditis. It can cause a uremic frost that develops on their skin, right? And where did BUN come from? There's my turkey I was looking for earlier. So the turkey gets broken down from protein, and it forms urea. So one of the strategies is to recommend a low protein diet. It's kind of dubious, but if they're on dialysis, though, we don't recommend low protein anymore, because dialysis is going to pull out protein. So we recommend just a high protein diet, actually, where they are on dialysis. So our goal here, because dialysis itself will pull out the BUN. So it's like, well, which one are we doing? We are going to encourage a high protein diet, and also make sure make sure they go on the dialysis. Otherwise, you're going to get complications of elevated BUN. And what happens when BUN is elevated? It does all kinds of bad stuff, nothing good. So it's going to cause more inflammation, which will cause more kidney damage. It causes inflammation of the vessels of the vasculature, which will cause us to be at risk for atheromas to take hold, and it cause more hypertension and more CAD, CHF, and then more kidney damage. And then it also stimulates the SNS. So you have more SNS tone and more hypertension. And then you have a high risk for hypertension, more inflammation, and further kidney damage. And what else does it do? It's going to also, you have a lot of parathyroid hormones circulating around. Parathyroid hormone's job is to get to release calcium and phosphate from bone, right? And also encourages absorption from the GI tract via vitamin D. So it's telling the bone to break down calcium and phosphate, and calcium keeps getting low, and low calcium stimulates parathyroid hormone. So you get what's called hyperparathyroidism. You get a whole bunch of parathyroid hormone that keeps breaking down bone, the phosphate keeps going up, the calcium keeps going down because it's binding with the phosphate. And what else happens is that mixed with BUN, unfortunately, those three things together, calcium, phosphate, and BUN, causes calciphylaxis. It's a hardened ulceration of their skin, and it actually calcifies the arteries. If the SNS tone endothelial damage did cause ASAVD to take hold, this definitely will. And there's a really high risk factor if someone's getting warfarin as well. That's like the thing that's going to definitely make it happen. Okay. So what else can I say that's bad about BUN? So it also interrupts platelet function. So our platelets don't work. So if we have platelets not working, what's going to happen then? We're going to be at high risk for bleeding, bruising. So pre-procedure, they give DDAVP, and that's going to like jumpstart the endothelia and make it so that these different platelet factors, a factor 8, von Willebrand's factor, are actually going to help them coagulate for a surgery or for a procedure, right? So that's one of our fixes for someone who has uremia. Does it fix uremia? No, it just fixes one of the symptoms of uremia. All right, so DDAVP prior to any procedure because they're a high risk for bleeding. And then lastly, what does it also do? It suppresses the bone marrow. So it's going to decrease EPO directly. So the kidney was trying to make its EPO. You try to give him PRBCs, you try to give him the ingredients to make RBCs, but it actually inhibits the production in the first place. So, getting the BUN under control is critical. And like I mentioned, there's no medical therapy to lower someone's BUN, or no pharmacological therapy, I should say. Their medical therapy is what? Dialysis. That's the only thing we can do to get rid of someone's BUN, right? So no RX therapy that we can use to lower someone's BUN. So we have to dialyze them, especially when you have, remember the AEIOU, right? What was U? That was uremia, because they have uremic toxins that are building up. That's going to cause damage to many things, and it's not great, right? It's going to cause all kinds of problems in of itself. But if it starts causing like uremic pericarditis, right, or encephalopathy, automatically it's time for dialysis. There's no skipping steps, all right? Or that is the only way you skip steps, is as soon as you cause pericarditis symptoms, or you have a encephalopathy with BUNs getting too high, that's going to cause a need for dialysis, stat dialysis even, right? And it's uremia greater than 90. So BUN greater than 90 is usually indications for dialysis. They go, oh, let's wait a little bit, and then once you start getting acidosis, I got 2 letters of the alphabet, that's dialysis time, right? But if the urea is like 100, 110, we might hold off, but as soon as they start getting altered, it's like, no, we need dialysis now, right? Or as soon as you start hearing a friction rub and you see on echo that they have like pericardial tamponade, that's a sign of uremic pericarditis that they need to then get fixed, right? It's not like infectious pericarditis. It's like a lot more calcified, like our deal here. But it's restrictive pericarditis, and it's very, very deadly. So lastly, our vitamin D situation. So vitamin D gets activated. Its final form is made inside the kidneys, right? So the kidneys are the final form of vitamin D. It's like when you get married 4 times, you have 4 last names. So it's called 125 hydroxide cholecalciferol, right? So it has all these activations that it had, right? So it got made in the skin by UV light. It got created, and it just took a stop at the liver, right? Went to school over there in the liver, got activated, and it finally goes to school in the kidneys and gets activated again. And that's the activated form. And what does vitamin D do? Its only job is one thing, and it has anti-inflammatory effects, but its only job with calcium phosphate is to absorb it for the GI tract. No vitamin D, no calcium phosphorus absorption in the GI tract, right? And again, it's not like absolute. There is a certain percentage, but it is basically your calcium phosphate are not getting absorbed efficiently from the GI tract, therefore at risk for low calcium, low phosphate. Well, why is the phosphate high? Because you can't get rid of phosphate, you can't get rid of calcium because I'm in renal failure, right? Also, when calcium is low, right, parathyroid hormone takes over, as we mentioned, right? Parathyroid hormone is stimulated when there's low calcium levels in the blood. So hey, calcium's low. I know how to fix that. Well, first of all, let's make more vitamin D. That's not going to work. But it's also going to say, I know where calcium phosphate is stored. 98% of it's stored where? No, not parathyroid. Parathyroid knows where it's stored, and it's stored where? Bones, right? Bones are made of calcium, right? So you have a lot of calcium in your bones. That's 98% of your calcium is stored there, and your phosphorus. So parathyroid hormone is like, hey, I'll be right back. And as it go over there, it's going to activate little osteoclasts, which cleave the bone, and they're going to spill calcium and phosphate into the serum, right? And hopefully the calcium phosphate goes up. But those guys are like bunnies, and they're calcium, let's go ahead, and they're going to neutralize each other, and then the calcium is going to come down, right? You can't absorb new calcium from the gut, and all the phosphate that you do break down from the bone is neutralized by the calcium that's already there, or not neutralized, but the calcium gets low as well. Okay, so vitamin D is what we need to give them so they can absorb calcium phosphate, and also we need to cut down on the parathyroid hormone. Yes, you could, but we kind of tricked the system. We gave them vitamin D so they absorb calcium phosphate. So whatever's in the gut, we're going to absorb, right? But we're going to leave the phosphate behind, right? So what's going to happen is vitamin D is like, hey, we're going to absorb calcium phosphate from the gut, and then someone took some agents that are going to neutralize phosphate. So here's vitamin D on the other side, so waiting. Where's phosphate at? Or where'd it go, right? And then, sure enough, it was neutralized into a hard mass inside the gut. The phosphate was neutralized and bound to, right? So that then the calcium can then freely get absorbed. Okay, so that's how these phosphate binders work. So phosphate binders are usually the mainstay of therapy. You see sevelamer so much because it also lowers cholesterol, and everybody has high cholesterol, so that's kind of why sevelamer is around. The actual best agent is these aluminum-containing agents. They're the most effective at neutralizing phosphate in the gut and allowing calcium to get absorbed, right? And again, calcium does not get absorbed unless you have vitamin D. So you need to have vitamin D, and that's going to be in our little fancy nephro caps, right? And then we have to have, phosphate binders. We have to lower the phosphate with those, right? So hyperparathyroidism is an issue, and sometimes they have to get a parathyroidectomy, take out the parathyroid gland, so doesn't keep breaking down bone. Because what are the symptoms of all this? Yes, if the calcium is so low, you get Trousseau's and Chavostex and ectopy can happen. But what else happens is asymptomatic, which is what? It's going to be osteoporosis. Osteoporosis has no symptoms until you break a bone. Then it has symptoms. And the mortality, whether you break a hip over age 65, is like 25%. It's greater than an MI, right? So it's an incredible risk factor that and these guys, the highest risk patients are those 50, 60, 70-year-olds, right? And you can see if someone's at risk for fractures, if you just multiply the calcium and phosphorus together, it's less than 55, that they're a high risk of a bone fracture, right? So let's say like a calcium is 5 and phosphate's 8. 8 times 5 is 40, right? So they're at high risk of getting a bone fracture. If we raise that calcium up to 8, right? Or that's going to 8 times 8 is 64, right? So that's going to help them out a little bit. Just another note is when your calcium is low, you always need to say what you should preface is say the corrected calcium is, right? You can't say the calcium is 5. You have to say the corrected calcium is 5. And why would the corrected calcium be 5? Is when the albumin is low, right? Because albumin is what carries calcium through the bloodstream. So if the albumin is low, our calcium would also be would be actually a little bit higher. Okay, so you correct calcium based on albumin levels. So it's 80% of a normal albumin, right? The albumin's 2. 4 minus 2 is 2, right? 80% of 2 is what? Like 1.8-ish, right? So calcium is like 6. 6 minus 1.8 is, or 6 plus 1.8 is the actual calcium. Okay, so the calcium is actually 7.8, not 6. And usually normal calciums are 8 to 10, 7.5 to 10.5, somewhere in there. Okay, so that's the idea with these calcium phosphorus issues. It causes osteodystrophy. It causes our bones to get weaker and weaker and weaker until they break.